Welcome, everybody. As I was introduced, I am Kelly Baskerville. I am a mid-career nurse. I've specialized in gerontology and leadership, and I've had mostly formal leadership roles in clinical education since 2001. I recently, as he said, completed my Master's of Nursing, which is a huge milestone, but it was a chance to really think about why I was doing the work I was doing. And I'm going to share my thesis findings today. So my big project and learnings, this is accumulation. Um, Given my history and the kind of things I focused on, uh, my discussion is more about knowledge translation and how do we operationalize what we've learned. I conducted a scoping review, which is a bit back, so I can't tell you exactly what works the best, but I can at least tell you the patterns of where we might be able to go. Now, I would like to acknowledge that I myself am a person living in Alberta, and I'm a third generation settler. I grew up and I still live and work on the home of the Blackfoot people and Treaty 7. That includes people like the Siksika, Piikani, Tsuut'ina, and Stoney Nakoda First Nations, and Métis, and it's Region 3 where we're at. And I acknowledge that this happens in a place where we have many Indigenous peoples, and we're sharing this information across quite a large area. And so I have a lot of gratitude for the ability to share this information and to learn together and hopefully take this learning and figure out how it's part of our efforts for reconciliation. Now, I have to say that, as mentioned, I was able to receive the Marjorie Boyce bursary. It's because of scholarships and bursaries I was able to be a student, and it meant a lot to me to receive that bursary from CAG. It allowed me to attend the Canadian Association of Schools of Nursing conference in spring 2024, and I was in progress of writing my thesis. It's the first opportunity I had to present my own work and get feedback from experts in nursing education. And this particular bursary was really important because offering an award that recognizes service to our community practice and to older people allowed me access. It's not always often that mid-career grad students have the same opportunities for scholarships. So to have that acknowledged and help move my work forward as part of my contribution, I just want to say thank you for that and for inviting me to speak today. My supervisor in doing this work was the excellent expert in gerontology as well as nursing education, Dr. Sherry Dalkey. The others on my committee who provided expertise in practical and technical guidance were Dr. Kathleen Hunter and Dr. Hannah O'Rourke. Also, big gratitude to Megan Kennedy, the academic librarian at U of A, who helped with our search, as well as the many friends, some of who are here today, who helped coach me through as I was writing and just learning how to do this research. Today, we're going to talk about some background on the issue. We'll talk about the scoping review process I underwent, some of my findings, but again, the most important part is what are the recommendations? We have about 10 minutes at the end to have questions and discussion, although we have a small group. So if you have a burning question earlier, you can either raise your hand or get my attention or speak up, and hopefully we'll move right through. Now let's talk about the issue. The population in the world is aging, which I think we've all heard about at this point. However, the proportion of people over 60 globally is going to be more than 20% of everybody by 2050. Now, 2050 is actually not that far away now, if you think about it. As a nurse, it means nurses are more likely to work with older people in every healthcare setting or every type of health service. Despite that, what we're finding in research is baccalaureate nursing programs, which produce registered nurses, are not adequately preparing nurses to care for older people. Although nurse educators are working to improve this, the most recent scoping review that examines a variety of research initiatives is by Koskinen and al. In 2015. They said it was poorly developed competencies, and they saw a wide variation in the quality of the studies, which meant it was challenging to figure out which education approaches had a potential utility for spread and scale up. Since that review, which was published in 2015, there's been a lot of changes in how education is delivered, as well as our increased awareness for the need for nurses to graduate with gerontological competencies. Now, gerontological education is important because as people age, they're more likely to accumulate both chronic and acute illnesses, as well as their presentation of acute illness can be different from younger people, sometimes exhibited through a change in their function, like alterations in cognition. So, gaps in nurses' knowledge can affect a variety of practice areas, whether we see somebody in a hospital, facility-based residential care, or community. If you're a nurse who lacks adequate gerontological education, you might think that functional changes are normal aging rather than an acute illness or change in that illness. It leads to inaccurate assessment and management of health concerns. Ultimately, that's a negative outcome for the person. It has implications for their family and community. If you think about it too, the gaps in gerontological knowledge, it leads to beliefs about nursing practice with older people as simplistic, not requiring specialized education, and physically heavy. So in other words, as one article I read said, oh, it's boring, when it referred to gerontological nursing and practice. It was quite a straightforward title. So we're looking at gaps in nursing education. Maybe it's part of a lack of nursing educators with expertise in gerontology. Maybe it's lack of preparation and perception about aging and care in the curriculum. Where is this coming from? When I was helping to host clinical practicum students in any of the communities where I was nursing or leading, I always thought, how are people being prepared? Why is this happening? As I went into my graduate studies, we looked at, well, where is the problem coming from? Because you always want to go upstream and figure out, well, where is this actually originating? So I took a look at the research. First, I thought, well, maybe it's faculty development. Maybe I thought maybe it's something else. In the end, I wanted to know what interventions are being tested, what's being researched, and is there any evidence that they work? So first of all, we had to know what's being tested. Several systematic reviews were done looking at gerontological education for healthcare professionals in general. There was two that took a really broad view, with one examining health and social scientists, students, and another looked at medical students. There was two in pre-licensure nursing education programs, but generally, it was not clear what specific interventions were being used. So everybody was classifying the education in a different way, which meant it's still difficult to figure out, if I'm an educator right now, what should I be doing? So we didn't know the dose, mode of delivery. We didn't know the outcomes were measured or the research methods consistently. When I looked at nursing, the ones that were probably best conducted were really much more focused on long-term care. And that's problematic because if you think about ageism, understanding how aging works and care of older people is not limited to one part of minority of people's life when they are experiencing disability and dependence. That's not normal aging for everybody. So if our education on working with older people is just people who are not working from strengths-based and ultimately displaying multiple chronic conditions, it's not giving us the full spectrum of what aging looks like or what a nurse's role is. It's only limiting us to a very kind of geriatrics view, not gerontology, which is more an understanding of how aging affects people in many different ways. Now, before I used that last review, which is Koskinen, I did take a look at that through the Prisma extension for scoping reviews. I wanted to see if that itself was a good quality review. And what I found is yes, although it wasn't perfect, it was pretty good. And it gave us really the bones or a leaping off point of where to start. So specifically looking at gerontological education in baccalaureate nursing programs. We took a global view, but we didn't have to redo the time frame that they had. We started at 2013, which is when they finished data collection. Now, we're trying to address some of the issues. There's educators, I think two of them are actually in the audience, three of them working on nursing education now. So if we had a map to share between educators and it helped us understand what's working and not, First, we need to know what's being published and what's out there. It's certainly never going to capture everything being done, but what's published is probably going to give us a good sense. Where are people looking? Is it gerontological focus or is it nursing education in general? We want to know, first of all, what's out there and what's being published. So, as a result, it was important for me to conduct a scoping review. Before I could take any one intervention and figure out whether it was really effective, we had to figure out what are the patterns and whether there was sufficient evidence in any one area that we could look at in a greater amount of detail. We are seeing increased pressure to deliver nursing education in online formats. That was certainly the case during the global pandemic, but we also acknowledge that online delivery was an issue before that was already being tested. The aim of this scoping review, in considering everything that's happened, is to map baccalaureate nursing student education related to aging and care of older people. After all, we can't try something new unless we know if it's been tested and whether it worked. Hopefully, I'll also have some insights that will help with other forms of education and health sciences as well. Now, I use the JBI scoping review framework for scoping reviews, which helped us have a framework that could be replicated. Our search terms were defined in consultation with an academic librarian using the concepts from Koskinen, as well as updated terms and library guides. We used the PCC, or Population Concept Context Framework. And you can see here our population was nursing students, defined as those who graduate from a baccalaureate nursing program to be a registered nurse. The concept was gerontological education, defined as education about aging and evidence-informed care of older people. Older people, of course, we had to have a common definition, was 60 years and older, and the context was nursing programs or education delivered in those baccalaureate programs for students. Our search procedure included looking at studies published in English. We didn't have money for translation, but there was more than enough for us to draw from. We started our data collection where Koskinen left off. So we included January 2013 to June 2023, and we included information about curriculum changes and individual education interventions. And we wanted to make sure it was specifically registered nurses that were graduating. It is amazing when you look at it, how many different variations there are in definitions of nurses and the kind of education going in. So we looked for as much a common definition as possible so we could still cast that wide net on a global scale. We didn't, in this scoping review, include any gray literature, opinion articles, or other reviews, partly because when we cast that net, we had a lot of results. Also, for reasons I'll explain in a second, we really wanted to understand the type of research being done, and so we needed peer-reviewed articles, which gave us the kind of information that would let us do a cross comparison. We used 2 reviewers to take a look through all of our articles, both my supervisor and I. We used Covidence to manage the screening process. I will just take a moment and say thank goodness for software like that, because it really saved us a lot of time in other ways. And I'll share our Prisma diagram with you in a moment. We looked at key elements in our extraction. Of course, we looked at the author year and article, as well as the country of origin, the study objectives. We also looked at what research methodology was used, data collection methods, data analysis, and we even found some new things Koskinen didn't have because we were finding new opportunities like framework analysis. It's not important until perhaps later we get to how we got to our results. It was interesting because the way that Koskinen divided their results on the education interventions, it wasn't a clean match. So when it came to data extraction, we pulled as much information as possible about what exactly the intervention was defined as, because it let us later refine and come up with clear categories to talk about. We also took a look at some of the other results I'll show you in a minute, which includes how did they measure their outcomes, what kind of key outcomes were used, and what was the level of success. Now, quality appraisal is not normally included in scoping reviews because scoping reviews are meant to be a map, not an evaluation. But here's the problem. Koskinen said they looked at the rigor used in the reviews before, and it wasn't very good. So it would be problematic to try and conduct a systematic review if going in you don't know that the studies aren't even of good quality. So in order for me to help make a systematic review more possible, I looked at the quality of the studies. I used the mixed methods appraisal tool, and it has separate quality or separate qualities or characteristics that have to be met for quantitative, qualitative, and mixed methods research. And it's a standardized method, which means when I conducted that, it's a way that anybody else could repeat it as well. Each study must clearly identify a clear research question, demonstrate the collected data aligns with other research questions, and it has to meet the quality criteria for the kind of research being done. For me, that was really helpful because if I want to operationalize any of this, if I want to put it into action, please tell me it's of sufficient quality that I have a leg to stand on. Now, I used two types of analysis, descriptive frequencies. I wanted to count how many times things were seen or how often they happened, but I also wanted to understand what those intervention methods were. So taking what Koskinen gave me, what I had to do is distill down what those education delivery categories were. Because if I didn't know how many studies were using the same or a different method, it was going to be very hard for me to map that out. So this is just an example of how I distilled out from an extract in the information down to what those categories were. This was, of course, a review, and so we didn't need ethics approval. And the findings were amazing. We identified the content of educational programs, the delivery method, their evaluation, and whether they had evidence that they had evaluated their effectiveness. And we could take a look at what those global patterns were. We started out with 2,583 studies, and with duplicates removed, it was happily a much smaller record to review. 1,465 records were screened. I will tell you, probably I thought my brain was melting at that point after screening so many, especially full text. But I think maybe data extraction is probably what I respect even more. That turned out to be, in my learning experience, an even bigger challenge. You think it's all going to be a consistent way that people are writing, and it's certainly not the case. So in the end, we ended up including 65 reviews. Now, here's the interesting thing about the characteristics. Every single one of the articles that were included described a different study. Some of them were a similar intervention, but very few. There was only 2 cases where we had one study reported in 2 articles. That's really interesting. So we have a lot of different things being studied, but not studied with follow-up or not shared. That was a big finding. We had 16 countries represented, may or may not have been because we were using English sources. A majority from the USA. Canada's in there, so I was feeling pretty good about that. Also Spain and Australia. We had no consistent pattern across the years, so there wasn't 1 or 2 years that had a majority of the studies. Although I will tell you, it was interesting, we also had China, Egypt, Hong Kong, Ireland, Japan, Korea, Portugal, Singapore, Sweden, and Turkey included. So it made me feel like maybe we were casting a wide enough net that we could see if there was some global patterns. 33 were quantitative studies, 20 were qualitative, and 13 were mixed methods. I was able to apply the mixed methods appraisal tool to them, and almost all of them met all of the criteria. So that was a bit heartening because we certainly want to see that good research is happening so that we can keep using that in a meaningful way. Here's some interesting trends. Although there was several education delivery methods used, which were clinical placement, classroom, clinical lab, simulation in clinical lab, online asynchronous, online, online asynchronous and synchronous, and community placement. So here's the ones that appeared more often. What although classroom was listed a lot, clinical lab was there. It was the simulation and e-learning that were new compared to Koskinen. Interesting that e-learning is not new as an intervention, but more people are studying that, particularly in how they are using it to teach gerontology. Clinical placement in community was a surprising finding. That was actually one of the most common because the settings for clinical placement varied. Most of them taking place in non-healthcare setting. It was older people's homes, community senior centers, that was followed by facility-based living and some with acute care units within hospitals. Why is that? Well, maybe because we're not classifying it as care of older people. Maybe we're saying this is your med surg assignment, or you're going to go study orthopedics, but it's not being identified specifically as gerontological focus. One was really interesting. It was in geriatric psychiatry in an acute setting, and that was interesting to see because now, of course, we recognize as people are growing and older, they come with everything that has been part of their life, as well as things that are emerging. So maybe for consideration, that would be something we do need more research on. The duration and timing of education. This was interesting. I wanted to know, are people only testing one off, one class? Is this over a whole curriculum? Well, here's what I found. Most educations were over a course or semester, where it's weeks of course or semester not defined, but saying it's over a period of time as focus. After that, I found shorter standalone interventions, which range between 10 minutes and 12 hours. So basically within a day or two. A lot of articles didn't specify how long the intervention lasted, which was interesting. And education happened at a variety of points. Nursing programs for baccalaureate nursing are between 3 and 5 years, depending on where you are in the world. Most of them provided education only in year 1 of the program. So gerontology was only directly studied and addressed in the first year of a baccalaureate program. That was followed by year 1, year 3, or year 4 or 5. So some were in the last year of the program, which maybe is a good representation of looking at complexity or tying concepts together. But it's interesting to see when that education was delivered. There was a few that were followed through the entire program or were included in the whole curriculum. For sample size, I'm just going to find that. It was an average of 82. And I got to say that seemed about right. Most of the studies used surveys or questionnaires to collect information. A lot of them actually did use student journal or assignments and went back and looked at what people had written. And some were interviews. Some used a combination of all three. So the number of students included certainly did vary. There was one study that included a remarkable number of students, particularly because it was qualitative. They had hundreds of participants. The reason for that was they had several classes of students over a couple of years who all completed year-long placement, who completed journals. And so what they were able to do is take journals over several years and combine that together. I think one study had only 6 people. This one had hundreds of students included. So a little bit of outstanding, but again, we're looking at an average of 82 participants, and most of them, because it's a study only in one place, Again, that's one cohort or one smaller group of participants. Now, I've mentioned mostly were questionnaires, written in interviews. The outcome assessments were really interesting. And here's the main categories that I looked at and slotted them into was knowledge, skill, and attitude. So knowledge, skill, and attitude are kind of the main ways that researchers are looking at. When you're educating a nursing student, does their attitude or maybe their ageist bias change? What is the perception? Because we're saying, well, maybe it's their perception of older people that needs to change. So we're saying, when I deliver this education, does your opinion or perspective change? Knowledge, often that was measured in people's written assignments or in questionnaires or quizzes that tested what it is they knew. Now, skill was a little more interesting. Some of that was observational around whether people were completing a task hands-on and whether or not they could answer a question correctly. So there was a little bit of overlap between knowledge and skill. Now, the most common by far, which is 69%, was attitude. 63% measured knowledge and 32 measured skill. 35 looked at all three. So, like about half of the articles were looking at, are all of these things getting better? But none of them looked at skill alone. So skill was not very often measured. Knowledge kind of, but attitude was by far the landslide of what was looked at. The way people measured this, aside from the general questionnaires or the other things I've measured, they took specific standardized tools. The most common was Kogan's Attitudes Toward Older People scale. So, like I said, it's our perception of aging in older people. The Facts of Aging quiz, which again would count as knowledge, and the Jefferson Scale of Empathy. Again, we're looking at attitude and perception. So with that, we can definitely see we're able to use standardized measure if we want to understand what our students are looking at or um, understanding. But unique to study, most of the questionnaires that were created that were unique to a study were on a specialized kind of medical or clinical topic like dementia or continence. So again, it was happening, but it was really unique. And again, it has a little bit more limits for replicability. So with all of those findings, where do we go from there? Well, we had so many articles, as ever marked, that were standalone. How do we test something and know that it works? If you test it once with one cohort under one set of circumstances, you're gonna be able to see what your result is. But if you want an intervention that you know will work for students over time or in different places, we have to test it several times. So please, if you're conducting research, please plan on how to have it retested and include different cohorts or different context. Without this, we're probably going to not make headway and we will keep reinventing the wheel. Recommendation 2, please include more research that has longitudinal measurement. I really like this picture that I found, in stock photos. This is what, again, the story I'm telling myself in my head is this is a nursing student working with somebody in their clinical practicum in their home, I hope. This is what I'm hoping for. They're learning about how to manage health. What happens to that nursing student 6 months later? Have they retained the knowledge, skill, or the change in attitude? What about 1 year later? What about 2 years later? Even by the end of the nursing program, has the person actually retained the outcomes you were hoping for? There was probably only 2 studies that included that repeated measurement, and I understand the logistical issues with that. But if you're retesting, again, that builds our information that'll help us use that intervention more reliably and know that we have a lasting effect. It'll help me as a future educator know which ones are going to last longer as well, not just help somebody memorize in time to pass the test and then move on and forget everything. Recommendation number 3, please include more education evaluation frameworks. I saw this in I think one study. And the challenge, of course, with this is if the goal is spread and scale of an intervention you think is really neat and really working, please have some sort of built-in way that you can tell people you're going to use to refine and update that intervention, because this is where it's going to start to be more contextually focused wherever you use it. But it's a way of measuring what you changed and why, so you have the paper trail. Please don't just do a research study one and done and then move on, because we know that things change over time and it needs to change with the people who are receiving it. It also needs to hopefully change with the input of the people we're talking about. This is a way of meaningfully getting input and refining based on what older people say about their own health. So if you do that and you're using the same framework to update and evaluate as, your friend in another university or another college, and you're evaluating and updating the same way, we have that consistency. And consistency is what I'm learning is really where we can start to work together a lot more effectively. Recommendation 4, more research should include measurement of knowledge and skill. And I've really struggled over the years as a supervisor of nurses and interdisciplinary team in providing them meaningful feedback. So in education, what I expected was a lot of that would be the same. I recognize that overcoming ageism and helping people examine their biases is really important, but more than just attitude, please do measure attitude, because it's part of your students gaining insight as to why they make the choices they do. But knowledge and skill is undermeasured in gerontology because we are underestimating the value of our expertise. And the way that we measure that, it's not perfect with competencies, but not only do you know what to do, but can you show me that you're doing it? Can you show me that this is reflected in the behaviors and actions you take in practice, even if it's in a sim lab, even if it's, in the first clinical placement? Please look at how you can measure knowledge and skill. This is probably an area that we need to grow, not only in nursing, but in many health professions. And we do have entry to practice competencies. How often do you take a look at that when you are designing your education intervention? And the last one, recommendation number 5. I am very happy to report that those areas that I found enough information that they're probably ready for systematic review is e-learning solutions, simulation, which of course can include many different kinds of teaching delivery. It's not just VR, and community clinical placement. The last one makes me the most excited. I worked in the community a lot. Most of my family were older people. There wasn't a lot of kids. And so understanding aging where most people are, which is in the community, and outside of areas that reinforce dependence, um, um, decline, and really kind of looking at meeting people as full partners in their care. This is a new opportunity, particularly given how I hear that the clinical placements and the options for that is dwindling, if not kind of an area of great challenge for educational groups. Looking at how to engage older people themselves and communities in order to help health professionals learn. Maybe we need to look outside of the formal organizations and think really creatively about that. Certainly, some of the studies I saw demonstrated that. So, this is the screenshot. This is a summary of my recommendations. Please test your intervention. How do you know it works over time for different people in different settings? Is the learning sticky? Does it stick in someone's brain? See if you can use a framework that'll help somebody next using your great idea to evaluate and refine and fine tune. And let's include gerontological competencies. So I just want to say thank you